Good morning. Welcome to Module 6, that is mandibular fracture. Fracture of mandible occurs more frequently than any other fracture of the facial skeleton. It is one of the serious facial bony injury that an average practicing dental surgeon may expect to encounter and treat. What is the most common etiology for the mandibular fracture? Most common etiology again as that of the maxillofacial fracture, that is the motor vehicle accidents, followed by falls 7%, industrial accidents, pathology or ballistic injuries, sports related injuries. Kruger has given a classification for dividing the mandibular fracture into various types, that is simple or closed fracture, that is a linear fracture line which do not communicate with the external environment. Compound fracture, that is open fracture, the fracture is communicating intraorally or maybe extraorally, intraorally through the mucosa or extraorally through the skin. Comminuted fracture, when fracture is shattering of the bone into the multiple pieces. Complex complicated fracture, there is adjuvant injury to adjacent nerves or major blood vessels or joints impacted. When fracture is firmly driven within the other fragment and clinical movements are not appreciated, there will be impaction of the fractures. Gynestic fracture commonly seen in case of children, only one outer cortex is fractured in case of children. Pathological fracture, spontaneous fracture may result as a result of the normal muscle contraction or trauma due to increased weakness of the underlying bone, that commonly seen in the large pathologies may be an cyst or tumor. Direction of fracture and favorability of the treatment. When fracture is viewed from the superior aspect, fracture either can be vertically favorable or vertically unfavorable. When viewed from the buccal side, we can divide it into according to fracture either is favorable or unfavorable fracture. This favorability depends when the muscle pull resists the displacement of fracture segments, then the fracture line is considered as the favorable. But opposite to that, when fracture pulls, distracts or pulls the fragment away from each other, resulting in displacement, then the fracture line is considered as unfavorable fracture. Unfavorable fracture, they are difficult to treat and may need an extraoral approach. What can be the clinical features for the mandibular fracture? First of all, there will be pain, swelling, difficulty in mouth opening, tenderness over fracture site, malocclusion will be there, or sublingual hematoma is pathognomic for the parasymphysis or symphysis fracture. You will see the bluish discoloration on the lingual side, that is the Coleman side. Inability to chew, inability to swallow. Then radiographic examination, we can go for various X-rays. Most common is the orthopantomogram, that is a panoramic view. We can go for lateral oblique view, posterior antral view, occlusal view, periapical view, reverse Townes view, or CT scan is required for when we have comminuted fractures or fracture of the condylar or ramus region of the mandible. Treatment goal basically is the first is the anatomical reinstitution, then immobilization of the fracture segments, then third is the prevention of any postoperative complication, fourth is the rehabilitation of the function to the normal function. Treatment can be closed reduction or open reduction. Closed reduction is that is the closed reduction and indirect fixation. Open reduction, that is the after visualizing the fracture segment and direct fixation is done. Button bandage for the initial support of the mandibular fracture. Then what are the indications for the close reduction? If fracture is favorable, we can go for close reduction. Grossly comminuted fractures, old age patients, fractures of severely atrophic edentulous mandible, lack of soft tissue overlying the fracture site, fracture in case of children involving the developing dentition, infected fractures are there, condylar fractures are there. Now, what are the advantages of close reduction? Close reduction is a daycare procedure, not requires any hospitalization. It is cost effective and safe, avoids damage to any vital structures. Disadvantages of close reduction is that there is a restriction of mouth opening for at least 4 weeks. Patient can take only liquid diet, difficult to maintain oral hygiene, challenging in partially edentulous patient can have weight loss or partial trismus for few weeks after opening the intermaxillary fixation. It is contraindicated in case of asthmatic, Parkinson's patient or mentally challenged patients. Now, what are the indications for open reduction? First indication is the when fracture is unfavorable or unstable fracture. Multiple fracture lines are there. If there is associated midface fracture, associated condylar fracture is there. When intermaxillary fixation is contraindicated or not possible because of the patient's condition. To preclude any need of intermaxillary fixation for patient comfort. to facilitate the patient desire for early return to work, or edentulous atrophic mandibular fracture with the displacement. Delayed treatment with soft tissue entrapment at fracture sites. What are the advantages of open reduction? Early return to function. Exact anatomical reduction under direct visualization. No need of maxillomandibular fixation in most of the cases. Less chances of postoperative complications. Disadvantages, most common disadvantages is as it is open reduction is there, done, so patient may require hospitalization. Risk of general anesthesia, we are doing under general anesthesia. Extraoral scarring, if displaced fracture is there, we are opening ramus or angle region by extraoral incision, so patient can have extraoral scar. Risk of injuries to the vital structure as we are directly near to the vital structure, that is the nerve and vessels. Expensive to patients when compared to close reduction. What are the various steps for the open reduction? Internal fixation for mandible. We can go for either intraoral or extraoral approaches. Extraoral is required for angle and ramus fracture, while intraoral incision can be used for the parasymphysis and symphysis or even for body fractures. Second step is exposure of the fracture site. We can easily visualize the fracture segment here. Then curating if there is any granulation tissue is there. Irrigation with the normal saline and betadine solution is done to clear out any granulation tissue. Then reduction of the fracture segment is done with the help of the bone holding forceps, or chin retractor is also helpful in the reduction of the fracture fragment. Then plates are placed, that is fixation. Immobilization may or may not be required after opening this intermaxillary. After plating, fixation of plates and screws, closure of the incised side, then pressure bandage is given over the surgical site to avoid any postoperative hematoma or any swelling. Then body fracture, single hole, 4-hole plate with gap below the root apex or inferior alveolar canal is sufficient for the fixation of the body fracture of the mandible through intraoral approach most of the time, except in the cases where extraoral soft tissue injury or scar is there or severely comminuted fracture is there. For the angle fracture, treatment for angle fracture still remain controversial. Open reduction is usually method of choice for unfavorable, simple angle fracture to avoid post-reduction, displacement of fragments or inconvenience of intramaxillary fixation. For ramus fracture confined to ramus are not common but rare, may be simple or comminuted. Simple, that is low condylon with both condyle and coronoid on the upper processes. Comminuted when relatively common and results from the direct violence. Fracture ramus of mandible are usually displaced. How? Why they are displaced? Because of the anatomical position of ramus is between the masseter and medial pterygoid muscle. And ramus fracture are conveniently treated by close reduction because of difficulty in access to these fractures and also because these fracture seldom causes derangement of the occlusion. So maybe sometime extraoral resistance submandibular incision provides adequate access for reduction and fixation of mandible. We conclude for the mandibular fracture that an adequate knowledge of diagnosis and management of various types of mandibular fracture is needed to provide the desired treatment in order to prevent any unfavorable and desired complications. Thank you.